Ellen? I will. For the record, I am going to elevate Representative Rosenwell to replace Senator Carson. Okay. Clerk, I think we have a quorum.
I think we do.
Okay. And there's nobody on Zoom, so we don't, at this point in time, have to do a roll call. So introductions, I am Gary Merchant, President Gary Merchant, the chair of the Prescription Drug Affordability Board. And to my left is...
I'm Todd Fahey, member appointed by the governor to the Prescription Drug Affordability Board.
Cindy Rosenwald, Senator from District 13, and I'm an alternate.
Thank you for being here. So we have an agenda before us. As far as board action, we do have a quorum. I'd like to keep a discussion on the financial update with the fiscal committee until Senator Sherman can join us, which would be after 11 o'clock. So that's going to be part of it. I don't know how much time Pharma needs for a presentation.
We can accommodate however.
Okay. If it's okay with those present, I'd like to move Pharma up earlier into the, so they have sufficient time. So why don't we have you come on board in about 15 minutes or so, if that's okay with you. And the reason I say that is that those who aren't here, this is all being taped and on Zoom, so they can go back and hear the presentation if they need to, if they want to, okay? Is there anything else that people would like to add to the agenda at this point in time?
No.
Senator Rosenwald, is there anything you'd like to add to the agenda?
No. Thank you.
I'd like to have a motion on the floor to approve the minutes from November 30th, and once we have that discussion on the minutes.
So, second.
Thank you. In regards to the minutes, I did make a note to Ms. Plurd that when is Representative Marsh, who was elevated to replace Todd, because you're on the Zoom at that point in time in order to have a quorum. So if we can make that change, I think the minutes will be fine. I don't think anything else in here I saw was being problematic. Does anyone else have any concerns?
None.
Okay. All those in favor of the minutes with noted change, say aye.
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 Those opposed, abstain. The ayes have it. The minutes passed. And Mr. Fahey, I want to commend you and Attorney Barry for the work you put into drafting these rules. There's a lot of work, at least I think it is. Is there anything in here you want to go over that we think we should be aware of, or you want some input from the board for clarification? How would you like us to proceed?
Thank you, Mr. Chairman. A lot of credit goes to Attorney Barry, who spent he took the laboring oar on this. So we had an architecture of the rules, as you know, and we promised to deliver a working set of documents for comment of the board and working toward a public comment. And we were happy to be able to produce that this time. So certainly we, my organization, we were certainly very involved with the drafting of the legislation that brings us here today. And we wanted to produce, try to find some substantive information to put into the rules so that the nuts and bolts of the work of this organization could be done and that the purposes of the law could be implemented. So what you see before you is the joint effort of Attorney Barry and I on that. And I think it's going to require further consideration by the board. A lot of words and 32 or 34 single space pages of rules. But I think it's a good working start. And again, the point of it is that the expectation of the legislature and the governor was that we need to bring some affordability mechanisms to prescription drugs for public payers in New Hampshire. The rules are consistent with that. And with that, I guess I turn over to Attorney Barry for other further comments, if that's okay, Mr. Chairman.
Thank you.
Thank you, Mr. Chairman, and thank you, Todd, or Mr. Fahey, I apologize. We're still in the very early stages, as Mr. Fahey pointed out. The idea was to get a draft out to the public to begin the initial commenting phase. We're not in the formal rulemaking process yet. I hope that at the conclusion of next meeting in March, we might be able to enter the formal rulemaking process at that point. I did have a conversation with the Administrative Rules Unit head here. Her name is Allison Zeno. She gave me some feedback that there will be some things we need to add to the rules, such as the board's procedures for motions and executive sessions and things like that, which is absent from the current draft. Ms. Zeno did indicate she's willing to attend whatever meeting you'd like to have her at, so she can go over that process of the formal rulemaking process. And so next meeting, I plan to have an updated draft based on comments from the board, from the public. And as for the public, they're free to reach out to me. My email address, I believe, is on the website, but in case it's not, it's robert.f.berry, B as in boy, E as in elephant, RRY, at dhhs.nh.gov. And I'm happy to start taking comments and considering those for discussion next time. Thank you.
If I can, also, we had a board member join us. So you can introduce who you are.
Sure. I'm Stacy Honan. I'm the Chief Pharmacy Officer at Dartmouth Hitchcock Health.
Thank you. So your recommendation at this point in time, do you want us to, as a board member, to go through and review this? Or when do you think we should start talking about letting the public know what we're drafting? Because we're concerned about rulemaking and how long it can take. Do we have to do them all at one time, or do we possibly go through this and do parts of them? What I'm trying to get to, we had a discussion on Friday about rules, specifically about fees.
Yes.
And I don't know whether we start at least getting that part of the rules through the process as early as possible.
So I did talk to Ms. Zeno about that. And you can go through a piecemeal process. It's not ideal due to some constraints with the way the rulemaking process works. It's better explained by her, but it is possible. My idea was that at this point, anybody is able to comment on the rules, the board, the public, and start providing feedback to me directly. And I was willing to compile that, put it together, and have an updated draft for the next meeting. But it's at the board's, discretion as to how that process is going to play out.
I would suggest maybe at the next meeting have her here. We can talk about that, but I think also for that meeting we should have something ready to go for public comments dealing with the fees, because that's the part right now it seems to be holding us up. And I think it's important we have a funding source with the board to be sure the board can do the work it needs to accomplish.
Sure. Currently there is a portion in the rules regarding fees. In rereading it, I think it's a bit vague and probably needs some updating to be more in line with what I would think JALCAR would expect. But there is a piece in there about that at this point. But yes, we can work on that for sure. And as I stated, the public can begin the informal commenting process at this point in time based on what we have ready to go.
So at this point in time, we should post these on the board website, the draft, and ask the public to provide some input. Or I'm not sure about the rulemaking process. I want to be sensitive. I don't violate something on the JALCAR. And then
certainly. So the informal process can begin whenever the agency chooses to do so. For instance, child care licensing typically begins a year ahead of time before they actually file the formal rulemaking documents. So right now we haven't filed anything formal with JALCAR for consideration. We're still in the informal process. Once we begin the formal process, it'll take about 3 months between the filing and the final adoption of the rules. My hope, or for the board's rules, was we submit something in March that would put us in the June or July timeframe, depending on when the meetings line up for final approval or final adoption.
Does anybody else have any questions about the sequence here? Because the way I'm understanding it, we have an informal process right now.
Mhm.
We propose draft of the rules on the board website. We can entertain comments.
Yep.
At that point in time, we can take all of that information, redraft the rules based upon the input and based upon what you and attorney Fahey come up with. Then we can have a conversation in March about all this work that's being done. But in March, are we approving rules at that point in time, then open up for public comment? When does the public comment start with rulemaking the jail card?
So the formal public comment period will begin once we file the rules with jail card. I'm not overly sure of the timeframes, but there will need to be a public hearing for that as well, and usually occurs in this room, where the rules unit will come down and anybody who wants to comment on the proposed rules will be able to do so. But that's the formal commenting period that's required by 541A.
Okay, so I'm clear about it myself. In March, what we're doing is finalizing our version of the rules. And we can then vote on them as a board.
Yep.
They then go into the formal process for public comments. And public comments, we could schedule a meeting in May, which is the next board meeting.
Yep. Yeah. So yeah, we can do that. Yeah.
So we wouldn't be talking, we're not meeting in February?
No, we're not. We're doing it, although we could. I think one of the things that I'm beginning to realize is that because we're meeting every other month, it's
A packed agenda. I was just thinking, we're probably gonna need the better part of a meeting for the board to really go through and have the comments reviewed and considered and the workings of the rules discussed. So I don't know if we held a meeting in February, then we reserve the March meeting for that purpose, but there probably should be a meeting. It's gonna be a lot of work, I think, and a lot of discussion with public comment and input on the details of this.
well, I agree with you. And we look at our calendars and find out what dates available in February. Right now, it's a crazy time of the year, but what can we do? Just to be specific, we talk about the rules. We're not talking about anything else.
I think it should, I think that makes sense to you, Attorney
It
General?
does. Oh, okay.
Are you thinking end of the month, Gary?
I'm thinking more like, yeah, the 28th on a Monday, if that makes sense, or
That's not good for the Senate.
no.
We're on break that week.
Oh,
So-
you guys got a break in the Senate?
So I don't know what
Yeah.
Senator Sherman and Senator Carson's schedules are that.
Senator Carson informed me that she teaches on Mondays, so basically Mondays are out completely
Well,
for her it is, but we can still meet as a board and have the discussion.
the other thing is, well,
We have
I mean, I don't know about Senator Sherman.
yeah, I don't either. What we can do is, let's do this. When Senator Sherman gets here, let's talk about the schedule and
That's
see
fine.
what he can do. with
I mean,
that.
I could meet that week, but I don't know that he could.
Okay. What about yourself?
I can do this one. You.
Okay, let's go back and see when he gets here. We'll circle back with the schedule on it, but I think it's a good idea that we have a meeting specifically for the rules and dive into them.
Thank
you. Okay. Any other discussion about the rules at this point in time? Yes.
I did want to add that it is posted on the website currently,
Yeah.
and I've actually already begun to receive some comments.
Great. So people are.
So, yep, they were editorial comments from the Department of Insurance, but I appreciated them. You know, so any sorts of comments are welcome, including editorialization or typo corrections, things like that. There's a lot of work that needs to be done, but we'll get it done.
Okay, thank you. In regards to the, we'll move on to, I'm going to change a little bit here. On the Attorney General's, I did ask for one of the things that Senator Sherman had asked before was in regards to the governance of this board. And what I received back from Attorney Phillips, Sherry Phillips from the AG's office, was that the way she reads it, I think the way we all read the statute is the board is really independent. It's not something that's attached legislatively to the legislative body or to the executive branch. It's really a standalone board. And as a standalone board, it has its own rules and it's governed by its own rules, which are then passed through the Joe process. I've asked Attorney Barry to reach out to Attorney General's office to get more of a memo, because I would like to have something more official that we all can basically, whoever, go back to the memo from the AG's office saying this is the interpretation by the AG's office. Because there has been some confusion between, I think as part of it, we have so many legislators on this board. People have a tendency to look at it as a quote legislative committee versus it being truly a standalone agency on its own or board. So I want to be sure that that's clear going forward. Hey, can I? Yeah, this is not.
That's a question for a Department of Justice.
When they talk, okay, we can bring it up. Okay. I think we have Representative Murphy just joined us.
Sorry for my delay.
Oh, no problem.
Grafton County.
Would you introduce yourself, please?
Representative Jim Murphy, representing Grafton 12, Hanover and Lyme.
Thank you.
Yep, thanks.
Okay. Representative Murphy, would you give us an update on your part as far as the bill going through the House, where it stands at this point in time?
Absolutely, thank you. And thank you to to Representative Merchant for carrying the ball 2 weeks ago when I was away on the 11th. But House Bill 1566, which really is an amendment to our statute to change the executive director to a unclassified position, and also to establish a non-lapsing fund for our fees, was presented by Representative Merchant on January 11th to the committee, and is actually heading back to subcommittee, I believe, this Friday at 1 o'clock.
Thank you. What I would say is, when after presenting the bill to the committee, what the committee informed me was that we put into the bill, the unclassified position has to have a letter grade attached to it, which is a different RSA. So I wasn't sure how to get that into the RSA. So I asked Representative Murphy to include that in the bill. The committee informed myself, therefore Representative Murphy, the proper way to do that is you have to go through the Joint Committee on Employee Classification. They're the ones that determine what letter grade it should be. So I asked the question, well, how does it get into the statute if you don't put a bill through to amend the statute? They said they weren't really sure, but it does work. So we changed the language to go before the subcommittee to have it go to JCEC, and they'll assign it to a third party who does the review process, and then they'll come back with a recommendation to the committee to what it should be for letter grade. And then somehow it gets magically into the statute. Okay.
I was on that committee last term, and that's pretty much the way it happens. It's
that sounds very magical.
It's bizarre.
That's what they said.
I'm not sure I actually followed that, but I will. I accept it as magic, and thank you for clarifying that. Wow.
Yes. The magics of the legislature. That's all I can say. As far as the Senate side, I can give an update. Senator Sherman presented the bill before Health and Human Services. There was some concern regards to the alternates. The alternates we wanted to do is, if you're an alternate, you can replace anyone on the board. And Senator Gray was pretty clear that you want to be sure that the alternate can only replace the one assigned to that category. So the governor, the alternate can only be for the governor and so forth. His rationale was that he wanted to be sure that there was representation of the groups, if you will. So the governor will always have a representative, the Senate as well as the House. That was kind of his driving. So we have amended it to include that. The alternate would only be for the ones that are in their respective category. In regards to the conflict of interest, there was not much pushback on that. And then in regards to the change on the PBM, there was really no pushback on that. So hopefully this will all go through. Okay, before we get into the rest of it, on the main data, I is able to actually work with the people in the state of Maine, and they have the same issue we have, is trying to identify wholesalers, manufacturers, PBMs, and so forth. They were kind enough, after a 60-day public notice, they released their list to us to use, which we can then use to augment what we have for the Medicaid. The Medicaid is manufacturers that have a rebate. So this is going to augment it as far as the wholesalers. The downside to it is it's no email address in there. It's all mailing address only. So I have to work with the staff here if we can somehow draft a letter to give them notification that they should be registering with the board. That's kind of a courtesy to them. It doesn't obligate them legally from complying with the law. We're just trying to be proactive here and be show goodwill that we're trying to help people to understand what's going on, but they still have the responsibility. I hope to have more information for the next board meeting. And Nick, you want to get up here and talk about the presentation with pharma?
Thank you very much for the opportunity to join you today. For the record, my name is Nick Doherty, the Director of Policy at Pharma for the New England region. Pharma represents the country's leading innovative biopharmaceutical research companies. Since 2000, pharma member companies have invested more than $1 trillion in the search for new treatments and cures, including $91.1 billion in 2020 alone. I want to use our time today to walk through healthcare trends we're seeing nationally, as well as in New Hampshire and other states in New England, and how these trends are impacting patients' out-of-pocket costs within the state. We're living in a new era of medicine we've never experienced before. In 2020 alone, there were 53 new medicines approved by the FDA. But too many people are struggling to find affordable ways to cover their health costs. It's a very real problem, which we need real solutions. We at Pharma never want to hear patients say they cannot afford their drug costs because accessing the care they need when and where they need it is important. Now, if the out-of-pocket costs for patients weren't an issue, we wouldn't be here today. So we very much appreciate the opportunity to dig into these issues that we're seeing at a national and regional level that show the cost of prescription drugs have been stable. According to IQVIA's latest report, the growth of net prices, which reflect rebates and discounts, have been in line with or below inflation for the past 5 years. Specifically, brand medicine net prices declined 2.9%, and total net spend on drugs has been in line with inflation and grew just 0.8% in 2020. This, of course, does not necessarily reconcile with what patients are feeling at the pharmacy counter, which is why looking at the whole system is so important. We believe by singling out manufacturers as the only actor in the complex supply chain responsible for the cost patients pay at the pharmacy counter, too often these policies that are overly simplified and overlook the role of hospitals, PBMs, insurers, wholesalers, and even the government, each of which play a role in determining drug coverage and out-of-pocket costs for patients. As you can see on the screen, the three largest PBMs cover more than 77% of commercial lives. PBMs work with private insurers to decide how to structure drug benefits and determine patients' out-of-pocket costs at the pharmacy counter. You can see on the side, There's the formulary, the tier placement, accessibility, and provider incentives. We're going to dig into all of these issues as we move through the slide deck. Here we'll just quickly touch to show that retail and physician-administered medicines represent just 14% of healthcare spending. Within that, brand drug spending represents just 7% of total healthcare spending. And this share has been historically stable throughout the years. You can see here that over the next 5 years, net medicine spend is projected to increase from just 0 to 3% per year. And over the last 7 of 10 years, retail drug spend grew more slowly than total healthcare costs. And on average, spending growth for retail meds is lower than that of total.
Can we ask questions
Sure.
during his presentation?
Is that okay with you?
Totally okay.
Oh, okay. So on the slide you were just on, 5, the supply chain entities, what are they?
So I believe there's been a number of folks when they presented here, they've talked about there's the manufacturers, the PBMs, the wholesalers, the pharmacies, the providers. They're all part of the supply chain.
But okay, so I guess my question is, why do you include them in the 14% with the manufacturers? Why only them? Why wouldn't you include prescribers?
That they would be considered part of the supply chain, as all the actors that are involved. As we dig into this slide deck, you'll see, I think it's slide 8 or 9, everyone who's laid out that's a part of the conversation and what makes the supply chain so complicated to understand.
So physicians are included in the 14%, but then they're double counted as the 17%.
So on that slide deck, or excuse me, on this slide, what you can see is this is total healthcare spending. So there are other parts of the healthcare as a whole where this is how it's broken out differently.
I'm just not understanding.
So I think what he's
they're
trying to
making.
say is when we look at the whole pie of healthcare spending, the physician and clinical services are the technical components that get billed out for, versus the 14% is truly just the drug spend.
So what's the supply chain?
So
we
it might be easier to visualize it. And do you want, if it'd be okay, we can move to that.
I'll just be quiet. It's just, this chart does not make sense to me. I'm sorry. That's right.
Can I ask a follow-up question?
Yes.
So your slide 5, to the senator's point, is purports to be the breakdown of the pie of a hypothetical $1 expended on healthcare. So if you were gonna, if I can just finish the question, that's the first piece, right? But then in this, you're putting in every possible aspect of healthcare, nursing homes, dental care. So the denominator is everything that goes into that $1 to keep me as a human being healthy. Is that a fair assessment of this slide?
On this slide, I'm going to have to get back to you exactly how it's broken down, and the source of which, if it's $1, for every single aspect of spending in total healthcare expenditures. This was really just to show that spending on pharmacy is just making up 14% of total healthcare expenditures, and then we broke it out. Tried to make it even more clear of breaks into brand, generic, and then other supply chain entities.
No, and I appreciate the comprehensiveness of it, but the bigger the denominator, the smaller the numerator.
Right.
So thank you.
Yeah. So, okay, that. I think we just go on the sequence.
Go in your sequence. Okay. I think what you can do is maybe want to hold back. Oh, President Murphy?
No, thank you. I just wondered, does that include prescription drugs like over-the-counter medications? the pharmacy part of it?
This is just the pharmacy spending.
So just prescription,
So
no over-the-counter meds or like Advil or something like that.
Correct.
Okay, thank you.
You all set to,
Actually, can we go back to slide 6? Because I know there might be some questions about in 2014, there had been a spike in spending. And just want to highlight that was related to new drugs coming on the market, specifically the Hep C drug. But also there's a growth of patients under the ACA that were coming into the market for the first time. And that was the reason for the spike. Of course, you can see 2016 began to level off again.
so, when you talk about medicine or drug spending, we're talking about what the patient pays. Is that the patient's responsibility?
No, that's the total health spending growth of that year.
So it's healthcare in general.
Correct.
Okay.
So what you can see on the board that all of the data is pointing to the fact that net spending for brand drugs is slowing, and that spending is only, or drug spending is only 14% of total healthcare spending. Patients' out-of-pocket costs are growing. Now, this slide does look at national numbers, but on the right you can see what we're seeing in trends aligns with what is in the New Hampshire Insurance Department's annual report that found that premiums and deductibles for New Hampshire residents continue to rank higher than the US and most other New England states. And we will get into this a little bit deeper later in the presentation. And Senator, I know you had asked earlier about all the entities within the supply chain. There's been plenty of charts like this that have come before the board that we've seen that have various degrees of showing the complexity. So we did just want to include a refresher here of all the entities within the supply chain that go into what ultimately the patient is paying at the pharmacy counter.
So it's not the prescribers, it's just these 5 entities.
Yes.
To be clear though, this is dealing with pharmaceuticals that are purchased at pharmacy. This doesn't deal with pharmaceuticals that are given by a hospital or given by a physician. So it's really looking at community pharmacy part of it. So there's another whole part of it, which Francis Herman talked about, which doesn't get included here because the physicians that administer drugs in their office or a hospital that provide it or nursing homes and so forth, they're outside of it.
Handled very differently.
Okay, but so this, be clear about it, we're talking about the community pharmacy, CVS, Walgreens, and Rite Aid, and so we normally think about it as a pharmacy.
But what about the mail order pharmacy?
That would be in there too.
Would that be part of PBM, or would that be?
That would fall under pharmacy.
It would. So this is all pharmacy.
Well,
retail and
mail order.
And mail order.
But you're touching upon something which we'll get to maybe in a different presentation, is that sometimes the PBM owns the pharmacy.
Right.
So therefore there'd be a conflict, in my opinion, between the two, because the fact a lot of times the insurance company owns the PBM, owns the pharmacy. So it's becoming vertically integrated or horizontal, depending on how you look at it. But right now we're just talking about the pharmacy part of it.
But in this case, the mail order pharmacies are always in pharmacy, even if it's Express Scripts.
Well, I think that gets to the complexity of as Rep Merchant described it, sometimes the PBM can have the vertical integration where it is all of those things.
I would say in my mind, they're all considered the pharmacy because
Okay.
they're all licensed as a pharmacy.
Mr. Garvey,
Okay.
Okay. His presentation.
Oh, Representative Murphy?
Thank you. My question is, I'm familiar with the PBM's work in the hospital setting. I wasn't aware that, I wasn't necessarily aware of, or actually how they did work for the individual between, say, a prescriber and then the pharmacy itself. And I imagine we'll get into that a little bit different, but it sounds to me like the PBM has different roles depending on within the hospital or outside the hospital. Is that correct?
Correct.
Mhm.
Okay.
Yeah, they contract independently with the pharmacies on reimbursement rates for the prescription, and then they contract independently with the health plans to manage the spend.
So most patients or people that pick up a script at CVS are not really aware of the intervention of the PBM on their behalf. Is that correct?
I would say that's true. What most patients, at least what we see, most patients know what they're paying out of pocket, and that's what they get most upset about.
Okay, right.
But the inner workings of how that PBM actually works, I would say most general public does not know.
In most physicians too, I can assure you too.
Yes, I'm sure you feel the pain point of the prior authorizations.
Yeah, I do.
Yeah.
Thank you.
So if net prices are declining and spending is relatively stable, as the data has shown in the past few slides, yep, I'm not feeling this. The question we have to ask is what's going on. And nationally and in New England states, there's been a shift in how patients pay for prescription drugs that has resulted in higher out-of-pocket costs, as the gap you can see on the screen between list price and net price widens. Benefit design has moved away from static, predictable co-payments to include a much wider use of co-insurance and deductibles, both of which rely on the list, not the net price, to determine patient responsibility. Which, just to note, this is very unique in the healthcare system. Cost sharing for other services, such as hospitals and doctor visits, is based on a negotiated rate. Now, as the gap between list and net price is, oops,
Sorry, going back to your statement about the shifting to co-insurance and deductibles and benefit design, how long has that been in place for New England and in particular New Hampshire?
So we've been, the report that New Hampshire does, I think dates back to 2013 and can circulate that around after. They do a really nice job of outlining not only New Hampshire, but the trends in the US versus the other states in New England.
Okay.
I believe that's available at the insurance department's website.
Yes.
Can I ask, the price growth that you're showing here, does that include brands that are coming off patent, or are you making comparisons between things that were brands and stayed brands?
I believe this is just looking at brands, not as it's coming off of patents.
Okay, thank you.
So I want to follow up by Ken on that. That's a good comment. Because when something goes from a brand name to generic, it becomes multi-source. You're going to have a natural decrease in the cost of the drug. So are we conflating pricing decreases or including them with a product that, you look at all your brand names, you have 100 that are quote brand, and all of a sudden you have 95 that are brand, but 5 came off, that would be a decrease, natural decrease.
That's what I was trying to ask.
So are we talking about the 95 residual that remain brand all the time, or we're talking about the 100, which includes 5 that went down because of the price decrease because it became generic?
I can confirm this, but this is brand.
Okay.
All right, so as the charts have shown, the gap between list and net price is growing and it is significant. And this is a serious concern because you can see on the right side of the slide, brands medicines average net price is 44% lower than it is than its list. And this is a significant difference and is a major out-of-pocket expense for patients paying in their deductible. This is a concern for pharma as well, because we're becoming increasingly apprehensive that the substantial rebates, discounts, and other price concessions paid by manufacturers that should be going to reduce the net price of a drug which were $187 billion in 2020, are not making their way to offsetting patient costs at the pharmacy counter. So instead, patients and their deductible are being forced to pay for their drugs at the list price before their insurance kicks in. So typically in January, after the holiday season, as it's getting colder out, patients in New Hampshire and other New England states with a deductible are not receiving the benefits from these rebates and discounts that should be going to lower their out-of-pocket costs.
So are those rebates going to keep their premiums from rising as fast?
That's a
I mean,
really,
or are they getting stuck at the insurer or the PBM level and it's just not making its way back?
that's a really great question. The logic would be if there's an increase in rebates that are supposed to be going to reduce premiums, premiums should be lower, but the New Hampshire insurance report is suggesting that premiums are continuing to grow. In Massachusetts, the Health Policy Commission, which has been at this for 8 years, they found that premiums have tripled in Massachusetts. And as a result, more patients are being forced or choosing to go into high deductible health plans. And at the same time, the HPC found that there's been almost $1 billion more in rebates that have come into the system since they started tracking this number. So it's a really great question to ask where are the rebates going? They should be going to reduce premiums.
Good morning, members of the committee. My name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell. And I just wanted to note that a few years ago, I'm losing track of which legislative session, but we did pass legislation that requires rebates to be either used to lower premiums or to lower prices at the point of sale for the consumer. So there is legislation on in New Hampshire.
Do you remember what the bill was, Heidi?
I can find out for you, Senator. Off the top of my head, I don't have that. But
okay.
I believe it was Senate 63, and it was in
Senate Bill 63.
So if I may, to follow up, we passed the legislation. Do we have documentation that in fact that's occurring? Because of what I'm hearing is sort of a difference in how we look at the data. One I'm hearing is that data showing that the premiums continue to go up as patients' prescription prices continue to go up. And if we're giving all these rebates and so forth back somewhere, how can we then assure ourselves the legislation is working to bring down the premiums if the money's going where it belongs?
I believe that the carriers are required to do a certification for the insurance department as part of the legislation. There are obviously, if it's being used to lower premiums, there are other upward pressures on premiums aside from pharmaceutical costs that hospital and other provider care could be driving up.
All of that was tied into the legislation that created all of this. So I don't know that any of it was implemented because of that. It was all one big law that passed. Okay.
Senate Bill 63.
Senator Sherman's bill.
That would have been 2019.
I just can't remember the bill number, but I think it was all of that. I don't think any of that, it's also tied up waiting.
I think the effective date on that requirement has taken place. I can confirm that.
Thank you.
Just another quick question related to rebates and whatnot. Where do coupon discount cards fit into these numbers? Because there's a lot of angst around coupon cards and what that does for the overall healthcare spend.
It's part of the rebates, discounts, and concessions.
Oh, it is. Okay. Is there any way to break it out? Because I'd be really curious to know what's truly a rebate coming back to a health plan versus how much is going directly to a patient at the counter to offset costs.
And if it's possible to take a 44% reduction from the list price, is a way to break it out and saying how much of it's going to, what percentage is going to different discounts, rebates, it could be concessions. But is there a way to get down and say, okay, the 44%, this is not just going back to PBMs in the form of rebates, this is going back because of copay cards, whatever it is, you're considering to be a discount for that list.
So I think it would be complicated. I think every entity in the supply chain would have trouble answering that question because it's a number of different negotiations with different entities in terms of what is a manufacturer negotiating with a wholesaler, and then what's the wholesaler then negotiating with the pharmacy, and that would be a contract negotiation and manufacturer.
That raises a different question then. If we can't get into the subcomponents of the 44%, then I become more skeptical about the 44% because we don't have any way to support 44%.
Right.
So the
And the
components
list price
right.
is meaningless because nobody pays
list
it.
price. But I think if I could find a way to look at that 44% in its subcomponents, I then would be difficult to understand and have a good sense that the 44% is in fact where it needs. You don't know how what you use for math to get to 44%. It makes me nervous.
My guess is pharma does know, like this respective pharma companies themselves do know how much they're giving in coupon cards versus
Correct.
discounts to the payers and PBMs and whatnot. And that's just with conversations I've had.
I just wanted to, Tyler Brandon sent me a text and said he has his hand up, but he doesn't know if you can see him or not.
Can you
Several people have raised their hands, and I didn't know if we were going to start a public comment for the time period, or
he was just going to comment on the law that I was mentioning.
If you can promote Tyler, but we'll save the public comment towards the end because I don't want to open it up that way. But Tyler's got a lot of information I think would be very helpful for us. Thank you. And I see right.
I'm good.
Mr. Bennett, you have.
You should be able to hear me now. Hopefully you can.
We can hear you.
Great, fantastic. Sorry, I didn't mean to make this more complicated. I also noticed there was kind of a chat box, but I just wanted to confirm, yeah, there is a requirement to carriers to actually send in kind of a certification or attestation when they submit their form filings for products, indicating that any rebates are being used to reduce premiums. The other thing to consider is that we do have the medical loss ratio requirements that are also in place, which means a certain amount needs to be spent in terms of claims. So if the carrier or the PBM, and of course it's considered collectively, were retaining too much on that side, they'd end up paying rebates to members.
So, Mr. Brandon, can you help me understand then? Are they providing only a certification that they use the rebates to lower premiums, or are we collecting any data to substantiate the certification?
So a little of both. There is a kind of a certification. They have to sort of indicate they're in compliance with the Senate, I think it was Senate Bill 63 requirement, and it is in effect now. But separately, when they submit rate filings, they also have to sort of justify their premium changes and make representations about trends, their expenses, and anticipated loss ratios. So while the data are not separated out specifically by rebates and expectations around that, at least not in the form filing and rate review process, it is a consideration like any other medical expense. The information we use to produce that Insurance Department annual report comes through in a separate filing. And in that filing, we do collect the information on rebates, but we obviously report it in a very aggregated way. So that would be separate from kind of this compliance side of things.
Thank you. Anyone else have a question for Ms. Brandon? All set.
Thank you.
Thank you.
So I'm sorry, is that annual report happening? That was required beginning November 1st, 2020?
Yes.
Thank you.
Thank you.
All right, so on this slide, as we just we're really diving into all the rebates and discounts that are going into the system, the question might become why they've become such a big factor. We've highlighted 3 reasons. There's been the consolidation of the PBMs, as discussed before. There's 3 PBMs that cover 77% of all commercial lives, so that creates some competition. Formulary and utilization management of the formularies, trying to ensure that product has a preferred placement on a formulary. That has created some push for greater incentive, as well as an increased competition in the therapeutic classes when it's multiple drugs that are going to treat the same issue. So companies are working towards ensuring they have the best formulary placement as possible to access as many patients as they can.
What's pharma's stance on outcome-based contracts?
Like a value-based contract?
Or if I am taking a very expensive medication and I don't see or achieve the outcome that the therapy is supposed to provide, I as a patient shouldn't be paying for it, or the health plan or the insurer shouldn't be paying for it. And so I'm curious because there's a lot of discussion about outcome-based contracting to kind of drive and lower cost. And so I'm curious what the stance is on that.
Really anything that can go to help patients is what pharma is working towards. Want to work towards finding creative solutions of the best way to ensure patients are getting these new drugs, and they are at cost. So exploring whatever ways possible.
You could follow up on that, because I think it's a good point, is that when, give an example, my father is taking a medication at the list price of $250,000 a year. He's fortunate because he goes to the VA system, we're still paying for it. But if I'm looking to somebody who's acquiring something or using something at $250,000 and does the same therapeutic outcomes that they're looking for, is there some way that pharma is going to hold the person harmless and say, we'll give you a rebate back to it to help offset the cost of it? Because if you're paying for something that's not working, it doesn't make a lot of sense.
I mean, that would really boil down to an individual company decision. Pharma in general, as the trade association, is working towards, want to make sure the patients have access to the drugs and creative solutions. So I couldn't answer specifically for that.
Would you ask the people at the trade association where pharma stands on that concept?
Okay. Well, I mean,
I do agree with what you're saying. It's up to the individual company, but it's a trade association. Do you have a stance on it? Because that's kind of important, because as drugs become more and more expensive, and it's just, yeah.
Value-based contracts. So.
You do support the concept.
Okay. Thank you.
So really the overarching theme that we've been trying to hit on here is that any policy changes that can make a real impact at the pharmacy counter, we'd be supportive of. But we want to make sure any proposals or recommendations are properly accounting for all the actors in the supply chain. That's because for the first time since a research group has been tracking pharmacy spending, in 2020 we saw it was the first time that medicine spending retained by manufacturer had fallen less than half of the total spending. So it's 49.5% was kept by manufacturers. The other 50.5% was going to other entities within the supply chain. So again, while the discounts and rebates within the system are growing, we have 74 billion in 2012 to 187 billion in 2020. And this is a result of significant negotiating power by the PBMs and plans. Patients are not seeing these savings. Instead, while the cost of drugs has remained stable, patients are paying more and more at the pharmacy counter, while other actors in the supply chain are absorbing the discounts that are being put in.
So I want to be clear then. So if we go back to slide 8, which deals with the stakeholders in the pharmacy supply chain, the manufacturers are keeping 49.5%, and the wholesale, the pharmacy, PBMs, health sponsor, so forth, are keeping the other 50.5%.
Correct. Yeah. So here's another way to visualize this real shift in where brand drug spending is going. Historically, you can see back in 2013, the bulk of spending went to entities that were taking on the risk from researching and developing new medicines. but that percentage has since fallen 17% over the years. And you can see on the screen, it's now just 49.5. So you can see how dramatically this change has happened. And it also coincides with the timing of a shift in how there's been an increase in consumer frustration due to the substantial consolidation in the PBM and health plan portions of the supply chain.
Can you also, if I may, does anyone know when Part D came on board? What year?
2001, I think.
2001.
About.
So it's been over 20 years ago.
Yeah.
Okay. Thank you.
I think it was right around that, wasn't it?
I think it's early 2000s, yeah.
Okay.
The other thing I would be really interested to know is what out of this growing red line is what percent of that is actually the coupons? Because again, that if you're lumping that into rebate dollars, but that's actually pharma giving money to patients directly, essentially, not actually going to the supply chain. So I would be really curious how that looks, breaking that up.
Everybody else asking questions? I can't run to the market. I want to be sure he's not telling me.
Does this also include vaccines, or is it just orals?
Well, this is the total brand spending. I mean, this would be before. Are you referring to COVID vaccines, or is this
just vaccines in general? Because vaccines are given in retail pharmacies, and so again, if we're talking about spending from a brand perspective, are we included the vaccine portion of meds, or are we not, and just talking about the orals and self-administerables? Because it all just factors into this conversation of what's included and not.
I just have a comment back to my $1 of healthcare spending. I mean, arguably, pharma is among the most sophisticated actor in the commercial realm in the U.S., right? So, pharma as a trade association, and obviously your members. Somebody needs to know. Somebody can say where all this money is going. I just can't accept that, given the complexities and given even with the rebates, somebody needs to be able to mathematically or just on a spreadsheet explain to people where the money is going. And it seems so complicated to try to figure it out. So I appreciate your comment, many of them in your slides, but this board, I think among other things, is trying to understand the mystery behind the complexity, right? And I simply, as a person in 2022, cannot accept that all of the actors in the supply chain, somebody can't figure out where all this money is going so that the person who is struggling to pay their medical bills, or the entity, public payers in our case, that is seeing the increase, is unable to understand the basis for the increase. So I just hope we can get to that. If not today, then at some point. And it's not a fair question for you, and I don't put it to you, but just want to make that point.
No, and I totally agree with you. You know, pharma has been on record long before I came on board that they want to be a part of the conversation. They've said the system is broken, the supply chain needs to be fixed. Not opposed to transparency. They just want to make sure that it's done in a fair way. I mean, trade secrets and confidentiality, proprietary information, that's the bloodline to ensuring innovation continues to grow. So understand, hearing the frustration, we want to be a part of the solution.
Thank
So this slide on the screen, this actually, this slide really caught our attention during the PCMA presentation that stated PBMs are only receiving 2.9% of the profits. It caught our attention. I know Rep Murphy, it caught your attention as well, because when we looked at the Fortune 500 list, CVS, which includes Caremark and Aetna, is listed at number 4. United Health Group, which operates Optum RX, is at number 5, and Cigna, which operates Express Script, is at number 13. Now, these three PBMs make up 77% of all prescription claims. So the findings that you can see here, they place manufacturers that take the enormous risks including an average of $2.6 billion of risk capital over a decade to develop just one drug, to receive only a margin half as large as that of the PBMs. Now, we do recognize the figures here are starkly different than what was presented by PCMA in their presentation. We believe PCMA's slide focuses on net profit, although the numbers on the slide are inconsistent with the cited report from USC, so it's not entirely clear to us where the number came from. But we do just want to point out, for companies in the supply chain, counting the cost of drugs, which are essentially pass-through costs as a part of revenue, will artificially inflate their revenue and make their profit margins appear artificially smaller. So the analysis that you see on the screen here is focusing on earnings, or the net profit divided by gross profit. So that's revenue or fees charged by a company to move the drugs. In order to remove these pass-through costs, you get a clearer picture. So you can't see it, the equation is on the bottom. I think you guys have it. It's a little bit clearer on your screen.
Oh, President Murphy?
Thank you. As I look at that slide right there, if you were to take out the manufacturer, the other four really represent what you've been describing as the supply chain. Is that correct?
Correct.
And if the manufacturers are indeed year after year, year over year, losing more revenues from the product that they make, and on the other hand, the patient is paying more or perceived to be paying more for the product. And if, again, it's a zero-sum game in the sense that, you know, there's only so many dollars in the pie that you can split up. It seems to me like somewhere in the middle of all of this, in the supply chain, that profit that was lost by the manufacturers is being eaten up by multiple actors. And my question is, where is the transparency within each of these various groups and the contracts that are signed between them? I know it's a large question, but it's just concerning to me that as a provider and prescriber, and also as a patient sometimes, you know, you see both sides of this. And I'm just concerned that this supply chain in the middle is totally obfuscated and I'm not even sure it's as transparent, or I'm not going to say regulated, but as understood as we would like it to be. Is that a fair statement? Or it's just confusing to me, that middle of the conduit between the manufacturer who makes the product and ultimately the patient that receives it.
So I think the question, it goes to something of what Mr. Fahey asked earlier, or mentioned earlier, of there are a lot of actors within the supply chain. There has to be someone who's figuring out where everything is, where all the funds are flowing to. And again, we'll stress, the pharmaceutical industry is not opposed to transparency. They want to be a part of the solution. As the slide indicated earlier, there was a spike in spending or expenditures back in 2014. The industry was told real in costs based upon the data, not just by sources like Akivia, but we saw Vermont, they had a transparency report that was released earlier this month that showed that WAC increases since they started tracking the information have gone down 82%. So we're, I'm really here, I can only speak to just one actor within the supply chain, but I'm trying to stress that it's very complex. Manufacturers are trying to do what they can to lower the cost of prescription drugs, but it's just, they're one actor in there. They cannot control the plan design. They cannot control formulary placement. Those are ultimately decisions that fall on other entities within the supply chain.
Can I ask you, what would this chart look like 20 years ago, or even 25 years ago? What do you think, what would you, it's a hypothetical question, but I'm trying to imagine back when, practicing 20 years ago, I don't imagine it looked like this, because it did not feel as complicated back then.
I can't even speak to how it would look 20 years ago. It's an industry that's really taken shape with new policies that have been put in place. And that's the complication that we're trying to peel apart the different layers and ensure that ultimately the drugs that going towards treating people, these life-saving treatments are getting to them in an affordable way. So it is a hypothetical question. I wish I had a better answer.
So I guess my just a more clarification for that, I guess what I'd say is there a way that you could retrospectively look at this chart 5 years ago and say, did those numbers, did the insurers make less, or did the distributors make less, part of the pie? Is there a way to look at that retrospectively or not?
Well, so this chart is from 5 years ago. So the PCMA report is referencing data. I think it was 2014, somewhere in that area. So tried to find data that, in a similar time period. And this was
I think, President Murphy, what I agree with you, if we could see this over a timeline, like you did before when you talked about the 30% was going to the pharmacy supply chain, 6 was going to the manufacturers, and that was over a timeline. You could see it in the lines. If something like that could be done also with this kind of a chart, just to show how things have changed. Is that kind of what you're trying to get to?
Exactly. I'd just like to understand who among the supply chain has, in my sense is the PBMs have gone up substantially over the past 10, 15 years at least. So I'm just trying to understand where the middle of the pie or the supply chain, where is that dramatically changed? Where should we focus?
Okay, so something similar to maybe if you backed up one slide where
back up one slide.
Something
right
so if you had a breakdown of what the other stakeholders have been retained, is that the question that's being asked? Okay.
So basically here, what I'm seeing is that the red line is the accumulation of all the other stakeholders. There'll be a way to break it apart somewhat by stakeholder. So I can look at how much that's kind of the question.
Yes.
I think that's the question I was looking for. What about yourself, Representative Murphy?
Thank you.
Is that what you're looking for?
Yes, exactly. That's, if that red line, you're exactly right. If that red line was broken up, it would just give me, or maybe us, a little more understanding where in of those various stakeholders, where has the change been most dramatically seen?
Where's the change occurring?
Yeah, we don't have that as part of this, but we could check as Nick mentioned.
Yeah, because I would go back to him before is that when you have this, the same thing is that 33.2% had to come from somewhere. So looking for the components that made up the 33.2%. Because I think that's going to be important to what this Bay is talking about. I'm trying to get to is, where in that red line, what's happening?
I think the other big piece, if we go to the next slide, because this is a few years back, is the pharmacy component. We know the pharmacies are getting shut down. And we've just seen it more recently with the announcements from CVS and Walgreens shutting down major stores. And so as we think about what component the pharmacies are getting, they wouldn't be going out of business if they're making more and more of the revenue. So I would also want to be looking at who's going out of business, who's staying in business as part of this, because even as we talk about pricing and access for patients, we also need to talk about where can they access that. And if those access points are going away, it doesn't matter how cheap the drugs are because they still can't get it.
One of the other things I want to point out that if I look at this chart in the pharmacy supply chain, there are entities out there that own the pharmacy, own the insurance, and own the PBM. So 3 of the 5 are being owned by or controlled by one entity. So therefore, in a lot of ways within the market, how much that's starting to skew things. To your point.
I mean, I think as this is an older chart, it's a more recent data showing that those 3 that we talked about earlier is controlling 77% of the market. So it is capturing a lot.
So if we look back at the year 2020, the Senate Bill 222 which is a bill that I filed to license and regulate pharmacy benefits managers. It did not pass. There was a lot of pressure from the PBMs to not pass it, but would have required a lot of reporting about rebates, and we should just take a look at that language.
I agree. There is a bill, Senator, in the House right now about PBM legislation. So I'll be more than glad to circle back with you on that.
That would be great.
Because I think we could look at it from that point of view. But that would be helpful.
Because there's been a lot of consolidation. Where it stopped is the manufacturers have not combined yet with the PBMs and the pharmacies.
Yep.
Yeah.
Yeah.
Questions, or we good? So we have touched a lot about the rebates and discounts in the system. As one of those three factors that we mentioned earlier, formulary exclusion, those three PBMs that have control over 77% of the commercial market have a lot of ability to control what drugs go where on what formulary. The manufacturer certainly doesn't want to be left off the company's formulary, so they are providing rebates, discounts, and concessions to ensure that they are included. That's been a big issue for consumers. And then another is just the increased use of 4 or more cost sharing tiers. That's something that we've seen where plans have shifted from a simple copay structure where it was for a generic, a preferred brand and a non-preferred, to where they're now being sifted into plans with deductibles and or have 4 or 5 tier benefit designs.
Yes, so what kinds of plans are you talking about here? Because I see you refer to shared workers. Is this just like the full risk group market that states can regulate, or does this include the federally regulated self-insured plans?
This is looking at on a national level at the plans. New Hampshire, their insurance report did a great job of breaking it down. I don't have the ability to remember that off the top of my head, but I think that would be a good starting point to look at.
So this is just the ERISA market?
So this is the whole national market.
Only.
Looking at the entire commercial pool.
So in the New Hampshire report that comes up in the New Hampshire Insurance Department, there's something like this as well.
It looks at tiering, deductibles, and I believe coinsurance.
Okay.
We can, this slide deals a lot with what's happening on a national level, where net drug prices have remained stable. In fact, in 2020, they declined, but patients are experiencing greater out-of-pocket burden on their drugs, largely due to the shift in plan design by insurers and PBMs. You can see on the left side, between 2012 and 2017, the percentage of plans that employed deductibles for prescription drugs increased from 23 to 52%. So that's on a national level. Again, to reference that great report the New Hampshire Insurance Department does. This is something that they saw similar to what's happening in New England states, and provides a good source of how New Hampshire compares. The New Hampshire report found that insurers in New Hampshire are increasingly requiring patients to pay high deductibles before receiving their coverage, all the while premiums continue to rise. We've also seen the same issue in Mass. I know we touched on this earlier. The Health Policy Commission's data shows that premiums in Massachusetts have tripled since 2000, and they are growing faster than wages and salaries. In the HPC's report, they found that this rise in premiums have led to more people enrolling in high deductible health plans. Pulling directly from the report, the HPC report, the high deductible health plans now make up 35% of the commercial market. And at the same time, enrollees in non-high deductible health plans saw an increase in their cost sharing responsibilities. So the percentage of members in Mass with deductibles greater than $1,000 a year grew from 39% in 2017 to nearly 45% in 2019. So this leaves patients in the difficult position to choose paying the high upfront costs with premiums or hoping they don't get sick and are dealing with deductibles throughout the year.
Can you help me understand, why is there such a lag time in the dates? One is 4 years, the other one is back at least 3 years. What creates the lag time? Can we get data that's more current?
So it's costly for the companies to do this. So that's the data set that we're working with, is from that point. I know the Berkeley Research Group, they had produced a report that was looking up to 2020, but this was not one of the issues that they had been examining.
Thank you.
This is a Price Waterhouse report, I think, that you quote. I mean, this is again, not a fair question, but maybe a fair question. I mean, who commissioned it in 2017?
I can certainly check on that. Was not at Pharma in 2017, so we can try to track that down for you.
Thank you.
So this is the slide that we have up on the screen, sort of ties everything together of showing that what is happening here is patients, while they're in their deductible, are paying the discounted or the undiscounted list price. And what they are not receiving is the rebate, but the rebate is still going back to the insurers. So while the patient's in the deductible phase, they're paying the total cost, so the total $400, and their health insurer is still getting a rebate. And that, of course, goes to the problem that we're trying to highlight of the new plan design, or the shift in plan design that is resulting in more patients choosing a plan with a high deductible and being held to pay the undiscounted list price.
So if I understand that correctly, the patient's paying $400 for the drug because it's based upon the list price. At the $400 the patient paid, $260 went back to the insurance company, to the PBM or somebody?
Correct. So the manufacturer paid a $260 rebate. This is an example, just using the easy math. The insurer, or excuse me, the manufacturer is paying a rebate, but because of the plan design and the patient is still in there paying off their deductible, they're not receiving the benefit of that $260 rebate.
Yeah. Does this go back to what you talked about before in your initial slide presentation about where it's kind of skewed, where all of a sudden the patient's copay?
Right, because once the patient then meets their deductible, that 400 will drop to 20% of that, right? So $80 for the remainder of the year. But the rebates are still going back to the plan. Correct. So the plan's still getting the 260, even though the patient's dropped to $80, right? So it's like, you got to look at the total sum in my book, not just the, hey, we're in January and everybody's in the high deductible, but over the course of the year, what does that actually look like?
So even though the patient's copay goes down from 400 to 80, that rebate still goes back every single time it's being filled.
Right, because the plan's getting charged the $400 or the claim, right? The claim's at $400.
So I just want to say this again. I feel this is a very reflective comment, that we do feel like the negotiated savings are not making their way back to the patients at the pharmacy counter. So, don't want to sound like a broken record and say it again. So I would move along. We're trying to jump to the final slide here, and just want to say it again. We want to be a part of the solution. We're not trying to come. Pharma's not trying to come here and put the brakes on any of the work that's being done by this board. We want to be a part of the solution and have these 5 tenets to show that we're trying to come to the table and do what we can to make drugs affordable and accessible for patients. Sharing the savings, I know we touched on Senate Bill 63. we'd love to see that savings going at the point of sale. I know we talked about coupons, and that's been an issue that's happened up here in New Hampshire, where there's been a whether or not it's worthwhile to maintain the coupon program. Massachusetts, I know, again, just to go back, the HPC, they've been doing yearly studies on determining whether or not coupons should count. They have ultimately decided that when it is a brand drug with no generic available, it is beneficial for the patient. We'd love to see a program where those coupons can go towards a patient deductible. In that example, to ensure that they're not paying the $400 list price and having whatever coupon or concession from another third party go towards that deductible. And offering the lower cost sharing options to make sure, if it's the price of a drug, it's for chronic disease, that the patient knows exactly what that is, and having some insurance design. Sorry, Senator, do you have a question?
More of a comment, but I'll hold it.
Okay, and just having benefit designs that cover medicines from day one, and cost sharing caps to create predictability for patients when they are at the pharmacy counter. I know that was a lot.
I'm glad you brought up the coupons in the case where there is a generic available, because what's concerned me about coupons is it's an incentive to fill it with a more expensive brand name when there's a generic alternative available, because the patient's part, the immediate patient part, might be less than the generic copay, or if they're in the deductible phase. And that just me, but it's made me skeptical about the value of, but the impact of rebates on overall expenditures in the system, both the insured person and the carrier. But I'd be interested to see what Massachusetts.
So the study that was released by the Health Policy Commission at the end of 2020 extended the use of coupons so long as there's no generic available, because they found it was a great benefit to patients.
But that's a key part, if there's no generic available.
Anyway, that's a whole other discussion on generics, but I am really curious about the annual increases of the same drugs that are currently on the market. And so, when we're talking about a $2,000 drug that sees an annual increase of 6%, 7%, 8% with nothing else changing on it, I think that, how does that all play into this? Because again, that's impacting the list price, right? Those increases. And so to some extent, pharma is feeding into the system by causing those price increases. So
no, and I think that goes to, as we've said before, the system's broken, needs to be repaired. While the list prices are rising, the net prices have remained stable or decreased. And it's a result of those factors of formulary exclusions, PBMs having enhanced negotiating power to ensure, or for manufacturers to be faced with the situation of, if we're not providing enough incentives and rebates, we're not going to be given a preferred placement on the formulary.
Okay.
Oh. President Murphy.
Thank you. And maybe, Representative Merchant could help me as a pharmacist, maybe understand it. But my question is, with regard to coupons and rebates, how actively involved in general across the system, across the country, do patients have to be involved to get the benefit of a coupon or rebate?
Patients have to, in my opinion, be involved with it, but we also need to break it apart, because under the Medicare Part D, CMS has ruled that a rebate is considered an incentive, and therefore patients who have Part D coverage through Medicare cannot use a coupon. So that's the first statement. Number two, when you get into the coupons, a lot of times it comes sometimes at the pharmacy because the pharmacist is aware of the fact there's a coupon out there for the patient to utilize to help them with the cost. And sometimes it'll come from their associations for the particular disease that they have. And that's how a patient becomes aware of it. But also Stacey Herman is here, who's a pharmacist as well. So I'll turn it over to her comment to fill in what I did.
I guess maybe a more appropriate question is, well, I'll let Stacey answer that.
Yeah, I would agree with everything Gary just said. We also see patients get referred to coupons by their providers as well. So depending on where that is, and it's not just coupon cards now, we're actually seeing like Visa debit cards because of all of the legislation happening nationally to ban coupon cards. The other thing I would say is the state of California had enacted a ban on coupon cards, which I think drove what was proposed here in this state originally. And they found there was no shift to increasing generics with that ban on coupon cards, interestingly. So there wasn't really much of an impact of putting that in place besides potentially harming patient access to care. So coupons are really interesting. And I think once we get into more of the debit card, it's going to get even more interesting because that is even harder to track from an insurer perspective than a coupon card.
So I guess my question in a different manner would be then, how much monies are left on the table? How much benefit monies are left on the table from coupons, now Visa debit cards, or rebates that are not utilized because somebody, provider, pharmacist, patient, doesn't know about it?
I would say from my perspective, very little, because typically, at least for my institution, where we see the majority of these are in the specialty medications. So your $2,000, $5,000, $20,000 a month agents. The pharmacy is very aware of all of those coupon cards that are available. And typically if again, non-Medicare patient walks on and their eyes just about bug out of their head because they're seeing the cost, we're actively working with them to lower that price point out of pocket for them as much as we can. The other thing I would say is there's also grants out there that, it's not just coupon cards. There's a lot of other avenues to subsidize the cost of prescriptions. And I do believe pharma companies sometimes fund those grant programs as well, in addition to the coupon cards. So a lot of avenues to help patients get access. Typically, we're not seeing them for your Lipitors or your other more chronic disease state medications, but definitely the high cost specialty ones.
Great, thank you.
Mm-hmm.
Yeah, all set. Thank you. This has been very helpful, very insightful. In regards to other things on the agenda, Secretary, you want to introduce yourself to the ones in the audience, please?
Hi, it's Senator Tom Sherman. I'm coming from a Seacoast Cancer Cluster Commission, so all healthcare this morning, and I'm Senator for District 24, which is 11 towns on the Seacoast.
Thank you. All right. Moving on to the rest of the agenda, I have a fiscal update. If you want to provide us a little bit of what happened on Friday or didn't happen on Friday, that was a better way of saying it. And I'll see if I can fill around the edges with you as well.
Sure. So I attended fiscal committee on Friday in an effort to establish an account for the board so that you begin collecting assessments from the various entities. The request was tabled mainly. The committee seemed to be hung up on the absence of rules at this point in time for collecting these assessments. Is the gist of it. It was a very disappointing result, obviously, but that's where we are at the moment.
Well, thank you for that. I will also provide, if you have in your packet, it's some thoughts that I have based upon the fiscal committee towards the end of it. So what I wanted to kind of review with the board today is that I did talk to Representative Leishman and also Representative Edwards. They both raised different issues, and I wanted to get their insight to what they were raising and why. Representative Leishman is really focused on the process and gel card rulemaking. And in the statute, it basically says that fees should be done through rulemaking or through rules. That's where he's basically hanging his hat. Representative Edwards was talking about the cash flow, who's going to fund the board to get it up and running and so forth. So what I wanted to provide to you folks here today is sort of something I want to go back to fiscal with. And there's three options, if you will. One, we can continue down the path we have. I think firmly that the statute does clearly state $500 assessment fee. I think the board has the right, because of the law, to assess somebody for $500, but that's a discussion with the board and people on the fiscal committee whether it will apply or not. Option two, which is option B, work with the fiscal committee to transfer funds from the general fund, maybe coming from the rainy day fund or someplace else, the $250,000 to help fund the board with no payback. Just fund the board and get it up and running and start. And option C was work with the Department of Health and Human Services Commissioner, Sir Jevanette, to request a transfer of funds somewhere within the Department of Health and Human Services to seed the board and then have a repayment plan. So those are the three options I looked at today. As far as trying to get a feel for what we have in revenue, based upon the data I did receive from the main board, plus what we have here, I believe we're comfortable if we have a $500 assessment fee, which is the floor. We have about 600 to maybe 700 entities that would have an assessment fee. That would give us between $300,000 and $350,000 per year. And looking at the cost for the executive director, probably administrative assistant, as well as any kind of analysis or analyst, it's probably labor-wise about $300,000 per year, including benefits. We also need to be cognizant of the fact that we're probably going to have contracts with somebody to analyze the data, look at certain things, software, and so forth, which I say is about another $100,000 per year, which brings us to $450,000. So I think if we can get the $250,000 started, we can probably get going as far as get recruitment going on with the executive director. Once that person's on board, then it becomes up to them to find an administrative assistant. It should be really their choice at that point in time with their personnel, along with an analyst. But I think if we can get at least $250,000 somewhere, we can at least get this up and running. Mr. Chairman?
We are blessed with the presence of an absolute financial genius.
That's a scary thought.
Senator Rosenwald, who sits on fiscal, first of all, we would not have access to the rainy day fund because that's something else. But one of the things that we talked about was whether this could either be an MOU with the department or a loan rather than a grant paid back, since we're anticipated to be self-funding rather than using general funds long-term. And so, Senator Rosenwald, I would love
so option A, I don't know if you could, whether, I mean, maybe the attorneys could tell us, yes, the board could start invoicing or not. Option B, Senator Sherman's right. We would not be able to get money out of the rainy day fund for something like this, but also the fiscal committee does not have the authority to appropriate general funds. So option B, I don't think is a real option. Option C, to get the commissioner to request a transfer of funds, I think that would require fiscal committee approval too. But it might just be fastest that somehow convince enough people on fiscal to take that item off the table and pass it in February.
Would it help if we restructured it as a loan?
I don't think so. I mean, it was a one-time accept and expend of $350. If $350 is not the minimum, maybe you want to redraw the item to be $300,000 if that is the floor. But you probably need to convince, well, I'm convinced. I didn't vote to table it, neither did Senator D'Alessandro, but you need to convince 4 other members of fiscal to do that.
And I'd be more than glad to have the conversations with board members. I'm just thinking that it seemed to be that people were defaulting to Representative Leishman's concern about the rulemaking and whether that's going to, he won't change his mind. What my conversation with him is, he's pretty much staying with the process. He's very process focused. So my concern is that if he still wants to table it or to object to it, who can I talk to within the committee to try to find the other 4? Any helping?
Well, where are we on rules?
I mean,
Well, the rules we're trying to do, we talked about before, when we wanted to wait till you got here, Senator Sherman, is finding a time in February for us to come back and talk about the rules that we have before us, the draft, and spend a full meeting to just dive into the rules at that point in time, bring them forward so we can at that point in March approve a draft, get them up public comment, then hopefully have the public comment, and then hopefully by May we can get the rules finalized, maybe sooner.
So I was just going to ask Senator Rosenwald, and I know you don't have a crystal ball, but if we came back and asked for $50,000 less and came back with Representative Merchant, Chairman Merchant, giving an update, saying where we are, where we're moving forward, and why we need to have the funding now to open that account and be able to start moving forward with recruiting and all that. You know, we're really pushing everything at once. If we go sequentially, we're going to miss all the information coming in from the companies, which is part of the statute. So do you think that that would be potentially helpful? I
don't know. I mean, why does the money have to be there to start recruiting? Nobody would start this job before July, let's say, right? Even if the board started recruiting, it took Maryland 18 months to find someone. Is it necessary that the funding be in place to hire someone, or just be in place by the time somebody is ready to start?
That's a good question. My concern is that if I'm a candidate applying to a job and there's no guarantee there's fund there to support the job, are we going to, at that point in time, have enough candidates applying for it? Now, if we stayed with the classified and people doing within the state government themselves currently employed, that's less likelihood of somebody taking the risk of going for a job interview with the job not being funded because they already have the job as a backup within the state itself.
Well, except we're changing.
Yeah, we do.
That's currently in the legislature. So I guess I'd follow on your question, which is, do we need the money to open the account? I mean, I'm willing to put $1 in there. What do we need to open the account and be able to start accepting funds from?
Was fiscal committee approval required to establish the fund? So it's a 2-part item?
Well, the way I understood it, and this is not my my expertise.
Oh, mine.
But I understood it was to establish the account so we could begin to receive funds through the assessments, so we can begin the executive director search. That was my understanding of the.
Well, why do we need? I'm sorry.
Oh, that's okay. The other comment I was just going to make is, wouldn't we want some funds? Because if we want to do any type of analytics on the data coming in before we even have the executive director in place, wouldn't we need funding for that?
You would, but I think the question is, could we open an account if we don't? I mean,
well, who knows the answers to these questions?
So if I may, I believe in order to establish a position, we have to show we have funding for it.
Is it a Department of Justice requirement?
I believe it's an administrative services requirement. I can follow up with DHR folks right after this meeting.
So here are the questions that I have. what is the cart and what's the horse?
Right. Is this an
Do we
autonomous
have
board
to,
or
do we
not?
have to, so is rules first? And when we get rules approved, then we can go forward with recruiting. And we can open our account. And we can accept the funding, which will be coming in rather quickly. So is our highest priority getting the rules? And is Representative Leishman correct? Or can we just open an account without rules and be able to start accepting money without rules and without any fiscal approval? And then the third question is, do we need to wait for rules to be able to start recruiting? So, you know, the other question that's out there is we have legislation that's looking at changing the category of our executive director, which is a very big deal. And with this legislature, it's not guaranteed to pass. So which of those, what is the timeline that we need to go down and what does statute allow?
So the statute does mandate rules. I mean, there is sometimes they're discretionary, this is mandatory. So in fairness, it does say that. So it would seem to me that we decided if we can get everyone together in February, we would take a wholesale view of the rules with the hope of getting them. But perhaps we should just say, you know, at the very least, we need to deal with what 126 BB6 requires, which requires rules for the following. Procedures for drug transparency as required under Section 7, the adoption of all fees under Section 8, and proceedings for assessing civil penalties under Section 10. And any other matters required to implement under this chapter. So it would seem to me we still need to try to deal with the entire universe of rules at the next meeting. But at the very least, before we can satisfy, I think, some of the concerns on joint fiscal that I would defer to the senators, obviously serve on the committee, we still need to have those baseline requirements met.
So it sounds like we have to have the rules first. Sounds
like we do.
Well, just like,
but not I think it's an open question about opening an account, whether we can open an account. I mean, that's I mean, obviously we're making an assumption that we need it to open the account. But
that's what I'm trying to get to is, can we set up the account through a quote transfer within the Department of Human Services through an MOU with the HHS? We can seed the money, and then once the funds start coming into that account with rulemaking, if you will, we pay it back as a loan repayment. So it's kind of like a loan.
We don't really need any money. We just need an account, right?
Oh.
There was something in the chat.
Representative Murphy, sorry.
I was thinking about Senator Sherman's cart before the horse, or vice versa, and thinking, can we actually accept monies from any entities without being able to analyze data, give feedback, or that sort of thing? It would seem to me like you have to have an account, you have to have some sort of mechanics or mechanism in place to look at data and analyze it and then feedback before you can take the monies, or am I wrong about that?
I think you're wrong about that. Well, the only reason I'd say that, Jim, is that we're supposed to be accepting the data. It doesn't tell us when we have to be analyzing it, like it, although there are reporting requirements. But getting off the ground, to me, it sounds like the first thing we need is rules.
Right, I agree with having the rules first, but I'm thinking that we ought to be building the plane before we fly it, meaning that we ought to have a pilot on board, we ought to have a bank account set up, we ought to have rules established. I'm just thinking, I'd like to get this stuff moving as quick as possible. And I'm also cognizant of the fact that we have that bill before the House right now. And, you know, the statements thus far have basically said that this is going to be independently funded without general funds. So what would that look like to the body if, you know, we are asking for seed money to start up beyond the fees that come in?
Attorney, yes.
Yes, we can do that when we get into the non-meeting meeting.
Where is the authority for the board to hire an executive director? I can't
It's
find it.
In section 2 or 3.
yeah. I don't have the.
I usually bring the statute with me, but
I have the statute.
I think it's 2 or 3. But I have 12. Oh, it's 2 paragraph 6. Thank you, Attorney Haley.
Yep.
Okay, thank you.
I think we need to go through
So
the rules on. The question I need with censure.
Oh,
As well
yeah,
as can we
okay.
open an account? At least get that process, at least in the budget process. So when we get the rules all done, we haven't got to go back to fiscal. So we try to do things in parallel.
right. So one option is we open an account with nothing in it,
Mhm.
and then we start populating it with fees that are coming in, but we can't really set fees without getting the rules to set them.
No, but the board can accept funds, grants, and gifts from public and private payers, which is not necessarily a fee.
Frankly. So I think we need an account and we need rules. That's my take, but I'm not. Would you agree with
The
that?
department's legal
Yeah.
squad can be helpful.
I think Attorney Haley talked about possibly helping us out once we get into non-public. Talk about some strategies.
I think the board should just, I'm sorry, Mr. Chairman. The board should just make sure that we tick off the requirements of the statute to be sure that the rules at the very least contain those things, and the assessment of fees and penalties are things that are to be expected. And so, you know, we have a very robust set, and I'm not sure we fully developed those portions. We can easily pop those portions in, really, with any modification that the board requires and to be considered in February if we can get together.
And that brings up the question I think we talked about before. Now that some term is with us, before I know the term is going to have to leave. Stacey, so if we look at our calendars in February, the last week in February,
That's legislative break.
it's
It's actually the cusp, so it's mostly March, but
So I could make that Monday, but I didn't know if you could or
yeah, I won't be
Senator.
in town.
Okay.
And also remember, Mondays, Senator Carson cannot attend.
Mhm.
So you may want to pick a Friday.
uh, 25th, February 25th. That's a Friday.
At like 10. That works.
That works. Senator,
It doesn't work for me, but
what
I'm an alternate.
what other part of the day? Is there another part of that day?
The
that would work?
afternoon would work, but
Say 1 o'clock.
maybe Senator Carson.
Why don't we tentatively say 1 o'clock on that
Okay.
Friday afternoon?
That works.
That way we know
We have a quorum.
We have at least one.
Right. One of the. So 1 o'clock. Okay. And that will be specifically to work on rules. The whole meeting. That's what we got.
Yeah, and the goal is to have the rules ready to go.
Yes.
Ready to submit to jail car by the time we're done.
Okay. And one last thing, we talk about this before we leave on the pricing registration. I know you folks worked hard on what have we done so far. I know we sent out an email.
So on
And your
December,
email blew up. I knew that.
on December 14th, I sent out about 400 emails to manufacturers to remind them about compliance with pricing data, the attestation form, if there was no price increase, and for registration. As of Friday, the registration was at about 50%. About 30, received about 30 people with their separate pricing data, which I need to put into one spreadsheet because it's all separate. There are several questions daily which I'm currently trying to wrangle up and send to you. And I'm still working on that. So
Thank you for the assistance and what's going on. So I feel comfortable. I think you have until January 30th for registration, but we're dealing right now just with the manufacturing community. We actually want to get to the wholesalers, which would be the next step.
and just the manufacturers that are involved in drug review.
Okay. That takes care of this one. Any comments from the public? Right. No. In that case, I am going to recess this. We're going to go into a.
Holly has a question.
Who? Holly? Go ahead. You want to ask me? Ms. Stevens, you want to?
Yeah, can you hear me?
Yes, we can.
I just wanted to say that the presentations that have been coming in have been really great. I would just also encourage the board to consider looking at neutral sources as well to bring information before the board, parties that do not have an interest in the supply chain, to kind of get a sense of what the data they would bring. So that's my one comment for today. And just for the record, Holly Stevens, Director of Public Policy for NAMI, New Hampshire.
Ms. Stevens, do you have any recommendations about who to invite as a neutral party?
I don't right now, but I will check with some folks that I know, and I can send an email to the board.
Thank you, that'd be most helpful.
Okay, thank you.
Any more public comments? This has been very helpful to listen and have the input from the public. So thank you. Anyone else? I just want to also, in March, I did invite, who will be doing a presentation to us, is what they call a Pharmacy Service Administrative Organization, PSAO, which deals with the interface between the PBM and the pharmacies. They sort of negotiate it to help us understand from their point of view what they're seeing in their space. That's what's going on for March, and we'll go down this road with, again, people making the presentations. And Ms. Stevens, you get somebody that's neutral to it. I think it'd be helpful to have somebody who does have a vested interest in the supply chain themselves. Thank you. With that, I'm going to move into a recess, and we're going to go into a non-meeting meeting with our attorney, and we'll come out of the recess and we'll go back into public session, and at that point in time make a motion to adjourn. So if you guys want to stick around outside, you can leave now, or you can come back in for 2 seconds and listen to us adjourn. That's a tough one. Thank you.